head out my slides. Recording, good. So, it's not working. Continue. Okay. So, my disclosures: I've done speaking engagements for Amgen, and Lisa's told me the audience about my clinical work. So they gave me a topic tonight, talking about cardiovascular assessment, cholesterol screening, but also deprescribing statins. I've never been asked about that. I'll have a slide or two right at the end of the presentation. They've asked me to look at prescription of statin therapy, HMG-CoA Reductase inhibitors, with reference to PBS guidelines. Again, I haven't spoken much about that, but I did go back and have a look at PBS guidelines. And we'll look about investigations and management of people with complex lipid abnormalities. So at the end of the 2-hour webinar, I hope you have lots of thought about lipids. Lipids are not as boring as you may think they are. It's not simply Lipitor 80 and on with life. And hopefully there's a few challenging cases we'll discuss and take home some messages about how to prescribe statins, the outcome you're trying to get from prescribing statins and other agents, but also how to manage the more complex patient, the difficult patient who says, I really don't like taking these tablets. Do I need to take them, doctor? So in terms of the PBS, I went looking at prescription of statins, and statin therapy has become open therapy now. There's no restrictions on how we prescribe statins. A long time ago, when atorvastatin, rosuvastatin, etc., were first released, there were quite strict criteria on who could be prescribed statin therapy, whereas standard statin therapy appears to just be an open prescription now without any particular limitation. When it becomes an authority script for combination ezetimibe, atorvastatin, ezetimibe, simvastatin, ezetimibe, rosuvastatin, there are certain criteria. So I thought I'd just go through those with you just to sort of glean the facts I had looking at PBS. The first thing I found, this is taken straight off the PBS website, so the configuration is not perfect. And the only thing I wanted to take out of this little slide here was the cost of ezetimibe, atorvastatin 10/20 milligrams for a general patient charge in the right-hand column is $31.63 for 30 tablets. And that's quite a powerful combination of two cholesterol-lowering medications. Going back perhaps 10, 15 years ago, statins were very expensive. Atorvastatin was like $1,000 per year to the PBS. So they've become far more affordable, but this is an authority agent, ezetimibe, atorvastatin. So remember that figure, $31.63 for 10/20. What struck me was the 10/80, another 60 milligrams of atorvastatin was only a couple of dollars more per month. So they really have become very affordable agents and very powerful agents. The ezetimibe, atorvastatin 10/80 would drop your LDL cholesterol by an excess of 60%. So if you looked at prescription of statin ezetimibe combination, you have to have high cholesterol in conjunction with dietary therapy and exercise. And we'll ask you later what that means. And you've got to have cholesterol concentrations that are not controlled by the statin alone. Now, if you go to the fine print, inadequate control says not reaching the LDL target. And they need 3 months of treatment with the maximum tolerated dose of the statin. So what is the LDL target becomes a very important question. And we'll talk more about that. I'd like you just to ponder at the moment, maybe scribble down on the sheet of paper beside you, what is your target for LDL cholesterol, for triglycerides, for HDL cholesterol? For those who haven't had an event, the so-called primary prevention group. For those who've had an event, be it cardiovascular, stroke, heart attack, peripheral vascular, the so-called secondary prevention group. And I'd like you to think about a really high-risk group. And we'll all have patients like this who've had not just one event, but have had multiple events. They have progressive plaque, despite having the appropriate therapies that we are so good at giving nowadays. So think about primary, secondary, and very high-risk patients. I'll give you a few seconds, just write down what your targets for LDL, triglycerides, and HDL may be for those groups of patients. Okay, I'd also like you to think about what are your recommendations for exercise and diet? To prescribe statins, the PBS is saying you've got to have people with appropriate exercise recommendations, appropriate dietary recommendations. So just ponder what that means at the moment. So coming back to prescribing combination of ezetimibe and atorvastatin, that's the number 7957. You've got to have hypercholesterolemia, diet and exercise, not to target, and then all of these factors here. You've got to meet one of them. You either have to have, from the top, ischemic heart disease, cerebrovascular disease, peripheral vascular disease, diabetics with complications, Aboriginals with diabetes, very strong family history of premature ischemic heart disease. Patients must have or have heterozygous or homozygous familial hypercholesterolemia or a 15% 5-year risk. That's the PBS criteria for prescribing ezetimibe and atorvastatin. I won't go any more into the PBS today, but this does link into how do you diagnose familial hyperlipidemia. So again, I'd like you to sort of just ponder that for a second. What is heterozygous familial hyperlipidemia? What is homozygous familial hyperlipidemia? And how do you diagnose it? Now, this is a critical part of tonight's talk, because if you can't diagnose FH, familial hyperlipidemia, then you cannot prescribe the most potent agents we have as add-ons to statins, the PCSK9 inhibitors, for this very high-risk group of patients. So briefly talking about familial hyperlipidemia, I've borrowed this slide from a talk I gave for Amgen, so I'll give them credit for that. They're saying, and Australian data is up to 1 in 220 people in Australia have FH, but only 10% of them are aware of it. Now, homozygous FH, where you have double genes causing very high cholesterol levels, quite rare. I don't have any patients with this condition. They get very aggressive plaque causing problems at quite young ages, even teenage years into the 20s. Heterozygous FH is quite common. And if you go to a coronary care unit, like where I work, up to 1 in 6 people who come with premature ischemic heart disease have heterozygous FH. But you can't diagnose it unless you know the Dutch lipid score. So the Dutch lipid score is how you diagnose FH. And it goes through a series of questions about family history, about first-degree relatives with very high cholesterol level, particularly children, clinical history of the patient. So if you've had premature ischemic heart disease, man less than 55, you get 2 points. Tendon xanthoma, premature ARCUS. I have one patient who had a ARCUS cornelis, I should say, at a very young age. And then you have to know the pre-treatment LDL cholesterol. Now, how do we know what the pre-treatment LDL cholesterol is? Most people are on statins, and so you don't know what the pre-treatment levels were. Within the Dutch lipid score, they have a calculation, and you do a factor to multiply out what the current LDL cholesterol is by a conversion factor to reflect which agent you're currently on. For example, if you have an LDL cholesterol of 2 and you're on ezetimibe and atorvastatin, 80-10, 10-80, you multiply 2 by 2.5, you have an LDL pre-treatment calculation of 5. An LDL of 5 would give you a Dutch lipid score of 3. You could combine that with the clinical history of a young patient, and you come into possible FH territory. If the pre-treatment LDL cholesterol level is much higher, then you come into definite FH territory. So I'd like you to sort of keep in the back of your mind that we need to be aware of the Dutch lipid score. There are very nice phone apps to calculate this. You can get them online. There's paper-based ones as well, which is what I tend to use myself. But if you have people with a high LDL on treatment, by high I mean LDL of 2.5, 3, you've got to think these people may be FH. So I'm going to do a case study. This is Mr. FH. It's not his real initials. He's aged 40. And he came into hospital a couple of weeks ago. He presented to a regional hospital not far from Adelaide with chest pain. Troponin was elevated. He was diagnosed with an NST-EMI, non-ST elevation myocardial infarction, with an ECG showing some inferior T-wave inversion. and was transferred to Flinders. He came down pain-free. We met him. He was on perindopril 5 milligrams for hypertension. At age 40, he'd stopped smoking 5 years earlier. He did say his cholesterol had been up a bit, but wasn't sure of the figure. So this gentleman is quite young, coming in at 40, not smoking for a number of years, not diabetic, family history negative for premature ischemic heart disease. This is his coronary angiogram. So this is his right coronary artery. I'll play it again and try to freeze it. So if you can see in this area through here, there's a very tight stenosis in the right coronary artery. This catheter here is 2 millimeters. The artery up here would be 4 millimeters. It tapers into a very tight stenosis, and there's a filling defect downstream here, and that's thrombus. That's clot within an artery of the right coronary artery. There's diffuse stenoses right through here as well, and this is more normal caliber vessel out here. So he's got a ruptured plaque with associated clot in his right coronary artery at age 40. Unfortunately, he also has other disease. This is his LAD. And the LAD is coming down towards 6 o'clock. Again, a 2 millimeter catheter. This would be a 4.5, 5 millimeter left main diameter. You can see through here, the LAD's tapered be quite tight, up to 80% through here with more disease distally. And this is his circumflex artery. And again, there's a very nasty stenosis coming through here. The circumflex more normal caliber and almost occluded over a long segment. And this is the obtuse marginal, there's disease here as well. So this gentleman at 40 has very severe coronary artery disease. And at age 40, he's been referred for a bypass operation, which he subsequently had. His long-term prognosis is poor if we don't get on top of his cardiac risk factors. And even then, he's got such progressive plaque in his coronaries. At age 40, I'm worried about his long-term. When he said his cholesterol was up a bit, at Flinders, we had records dating back, and it's hard to read the date here, but it's the 27th of October 2007. And his cholesterol was 13.2 at age 26. So this gentleman didn't have cholesterol up a bit. He had very high cholesterol levels, off the scale high. This is his presenting blood in May, a couple of weeks ago. Glasses on. Total cholesterol 13.8 with triglycerides of 10. Now there's no calculation of LDL there, and this is because of a trick of the pathology groups. They don't actually measure LDL directly, they derive it from what's called the Freeboard equation. I only want to go through this because it's important to know this so you can work out the LDL pre-treatment, so you can work out the Dutch lipid score so you can prescribe the appropriate therapies. Basically, the Freeboard equation says that LDL, which is not measured, it's derived, equals total cholesterol minus HDL cholesterol minus triglycerides divided by 2.2. The equation is not valid if triglycerides are over 4.4. This gentleman's triglycerides were 10, hence there was no estimation of LDL cholesterol. So how could we calculate this man's LDL cholesterol? I put the question to the pathology group at Flinders, and you could do a direct LDL calculation on the blood. 3 weeks later, we're still waiting for that result. Any ideas how we could work out what his LDL cholesterol might be?
And just type that in the Q&A box, folks.
Oops, tough question. All right, I wasn't sure of the answer either. So what we did was put him on therapy. This is the 23rd of May. His total cholesterol was 13.8 and his LDL was his LDL was not calculable. After only 4 days of therapy, his total cholesterol dropped to 7.5. His triglycerides were down at 4 and his LDL calculated at 4.8. I haven't got that on the slide, I'm sorry. It's an iPhone photograph taken last night to bring it onto a PowerPoint. So the point of this discussion here is that appropriate cholesterol therapy works very quickly. We put him on atorvastatin 80, which is what we use traditionally as a standard therapy for acute coronary syndrome, plus ezetimibe 10. So not strictly on the PBS prescription criteria, but we're trying to get his cholesterol down quickly. And within 4 days, his total cholesterol had dropped from 13.8 to 7.5, and his triglycerides had gone from 10 to 4. The point here is that people don't know how quickly these therapies work. They will drop your cholesterol quite quickly. In reverse, if people stop their tablets, it goes up quite quickly. You can actually overshoot and have risk of vascular disease when people are fluctuating with compliance. If somebody loses control of their cholesterol, the LDL cholesterol has always been 2 or whatever the figure was, and suddenly it's 2.8. The first question I say to them, do you miss a couple of tablets? Do you occasionally miss? Oh, yeah, I do occasionally miss, doc. Yeah, well, maybe around that time you missed a couple of tablets. Yeah, no, I was out for about a week. And if you miss tablets for 3, 4, 5 days, your LDL cholesterol will jump quite quickly. So we were able to work out what his LDL cholesterol was by getting him on aggressive therapies to get his triglycerides down, so the Freeboard equation worked. So for this particular man, his LDL cholesterol was 4.8 on atorvastatin ezetimibe. The conversion factor is 2.5. It puts his total LDL cholesterol up, didn't do the maths, but about 12. He is definite FH. And that would be a group where he could consider having gene studies done to work out if there's a particular genetic factor, which would be a risk through his family, but his LDL will get him over the line for diagnosis of definite FH and hence prescription for more potent therapies in the future. So I asked you earlier what targets people had for primary prevention, secondary prevention, very high-risk patients. I put someone like Mr. FH into that group. He's a very high-risk patient, having had severe disease at age 40. It's not a competition, but anyone wants to feedback where they think their targets would be for primary, secondary, and very high-risk patients? I'd be interested. Okay, good. All right, obviously the questions are working well. Okay, I'll move on. So I thought I'd briefly go on to diet and mention exercise briefly. Exercise, the Heart Foundation is fairly reasonable what they're prescribing here. Minimum 30 minutes per day, moderate intensity exercise as being what we're pushing out as the recommendation. I want to mention something about diet. Diet is something that is quite tricky with cardiovascular disease because it's changed quite a lot in the last 10 years. I thought I'd just throw you a few slides and a few studies which you might be interested in having a look at, perhaps reading. It sort of crystallizes my dietary advice to my people who amazingly have ischemic heart disease, but also have high cholesterol. So you're trying to get a balance between a group who have high-risk cardiovascular disease. Apologies, I'll come to diet shortly. The next part of the talk is a bit of basic science. I'm calling it Biochemistry 101. And so I think it's important for us to know more about cholesterol than our patients. So excuse the simplicity of this. So lipids are water-insoluble organic molecules. So I tell the students this in the hospital. If you fry up some sausages in a barbecue, you've got the fry pan. The fat in that fry pan, you cannot get it out just by adding water. It will not emulsify and become soluble. So fat in your blood is mainly water. You have to have it soluble. To make it soluble, it's carried by lipoproteins. So when people talk about good cholesterol and bad cholesterol, I'd rather they talked about good lipoproteins and bad lipoproteins. Cholesterol is a 27 carbon molecule. All of the cholesterol in your body produced by your liver comes from acetyl coenzyme A. That's a molecule from the Krebs cycle, from ancient history and biochemistry in our memories. So when you metabolize glucose, amino acids, fatty acids by the liver, you'll form acetyl coenzyme A, a 2-carbon molecule. That's repackaged by your liver into a 27-carbon molecule, cholesterol. The name, ancient Greek, from bile, solid, and alcohol. The ol from cholesterol refers to alcohol. There's the molecule. This little OH alcohol moiety on the side, 27 carbons. It's an essential part of cell walls, of hormones, of life, but it also creates all sorts of problems with vascular disease with our lifestyles. I want to briefly mention saturated fats. Saturated fats have no double bonds. So this is the traditional palmitic animal fat, 16 carbon with no double bonds. Monounsaturated fats like oleic, olive oil fat, have 1 double carbon bond, so monounsaturated. Then there are polyunsaturated fats, which will have more than 1, like linoleic, which is plant-based oil, or eicosapentaenoic, which has 5 double bonds, is fish oil. The other fat that's particularly bad is one we've created in laboratories ourselves as men, and that's trans fats. Trans fats are fats which are quite useful in the food production business because they're solid at room temperature, but at any heat will become liquefied and quite easy to use in processing. A trans fat has the hydrogen on opposite sides to the carbon double bond, whereas a cis fat has the hydrogens on the same side as the carbon double bond. So people talk about trans fat as being bad fat, which it is. It's an engineered fat to make it more soluble at lower temperature. So different fats again. Oleic has 1 double bond. Linoleic has 2 double bonds. Eicosapentaenoic, 5 double bonds. Saturated animal fat, no double bonds. And nomenclature, there's an omega and a carbon terminus. This is a polyunsaturated fat, 2 double bonds. The first one's at 6th carbon, so 18 carbon molecule, 2 double bonds. The first is from the omega terminus, 6 molecules in. So, are you still awake? Now, this paper here, I would recommend highly to you. This is from the New England Journal of Medicine, about 18 months ago. And it's a review of lipid management. And I'm going to show you a terrifying slide. This here, 40 lines. This is all you need to know about lipids. It's a very tough thing to read, so don't try to read it at the moment. I'll also show you this slide, which is a diagram of all you need to know about lipids. And all I want you to focus on this complicated diagram at the moment is that this is the liver. And within the liver, you produce cholesterol. We spoke about it. The cholesterol comes from metabolism of glucose via Krebs cycle. This is the endogenous production of cholesterol by the liver. You also get fats coming in from your diet, into your gut, into your circulation. And there's a continual circulation between the liver and your gut, back to the liver and into blood vessels. And if you're getting cholesterol over here into blood vessels, you can get plaque formation, vascular disease, and all the sequelae that cause so many problems of heart attacks and strokes. We'll come back to these diagrams later. want to talk about another clinical case. This is a case of a lady I saw a couple of years ago now. She was 45 years at the time. She was background from Southeast Asia, came to Australia as a baby post the Vietnam War. Her family history is unknown. She had a history of hyperlipidemia and was on rosuvastatin 20 milligrams per day. She was also on inhaler therapy. In 2018, she underwent breast cancer treatment with surgery, radiotherapy, and remains on tamoxifen. She was overweight, borderline blood pressure, never smoked, and didn't have any cardiovascular symptoms. That was her cholesterol in 2017 and 2016 on rosuvastatin 20 milligrams per day. So total cholesterol 5.4, HDL 1.3, LDL 2.2, triglycerides 4.2. So not to vascular targets, but she's a lady who hasn't had any vascular symptoms. So the GP contacted me. He was very concerned. This lady had an extreme increase in her cholesterol level. He excluded diabetes but didn't check thyroid function, which subsequently proved to be normal. These are quotes in the GP's referral letter. She had a significant cardiac risk and risk of pancreatitis. The GP increased rosuvastatin to 40 milligrams from 20, added the ezetimibe, and started fenofibrate 145 milligrams. Please see urgently. Now, this was the cholesterol level that the GP was concerned by. This is September 2019. Total cholesterol 21.9. I thought, probably not true. I repeated it was 20.4 on my repeat. Triglycerides 28.1 jumped to 35.6. Very low HDL at 0.4. And the LDL comment, which you can't read at the bottom, basically said you can't calculate the LDL if the triglycerides are this high. The old Freeboard equation again. So this is her liver function, renal function. They were fine. Glucose level was normal. Thyroid function was normal. She's not consuming alcohol. Any comments? Sure. I've been told to wait. Good. Yeah. I've had one comment from Mark Crawford, which I'll come to shortly. Consuming saturated oils from Helen Brower. She had a fairly standard diet. She was Asian background and had a fairly healthy diet as I went through it without consuming saturated fat, no. So just want to remind you what happened with the referring doctor. So this lady was on rosuvastatin 20 milligrams and it was increased to 40, added the ezetimibe, added fenofibrate. Any comments on that part of the management? Do people agree with the strategy of the triple therapy in those doses? Okay, so I've had feedback again, too many drugs. Why fenofibrate? Okay, so I just wanted to give you one of the messages that I learned with cholesterol treatment a long time ago. And this is lifted straight out of the PI of rosuvastatin. It's a quotation. So if you're using rosuvastatin in anyone of Asian background, be they Chinese, Japanese, Korean, Vietnamese, Asian Indian, Filipino, they don't metabolize statins like Caucasians do. And the PI says that there's increased risk of myopathy, particularly if you're using other lipid-lowering therapies such as fibrates. You shouldn't use gemfibrozole at all. And that in Asian subgroup of patients, we should start with rosuvastatin 5 milligrams per day and consider going up as high as 20, but not 40, because the risk of side effects is higher than the benefit. So I would be a bit concerned with this lady being on rosuvastatin 40 plus fenofibrate that she may have a risk of developing severe myalgia or rhabdomyolysis. So Mark Crawford nailed it in one. The cause of this lady's very significant decline in triglycerides was the addition of tamoxifen to somebody who already had quite high triglycerides. On rosuvastatin 20, her triglycerides are up to 5. Tamoxifen, there's a number of articles where it interacts in people who have baseline hypertriglyceridemia and causes massive escalation in triglycerides. So what we did, we stopped the tamoxifen. The oncologist has her on a different agent. I stopped fenofibrate and ezetimibe. I cut rosuvastatin back to 20 milligrams a day, gave her fish oil, which is quite safe in this group in terms of side effects, encouraged her regarding diet and exercise. Within 1 month, her triglycerides dropped back below 4, back to her usual baseline. So the take home from that is that if something's really unusual, to go to the internet, to actually go and say, oh, we're going to research this a little bit more, is quite a reasonable way to go. I don't have all the answers. I don't expect any of us have all the answers, but we can go and look for answers. We can talk to other people. We can be careful with side effects of medications as well. So a few take-home messages on that one case. Well done, Mark. I wasn't aware tamoxifen caused this until I went researching it. So I'm going to give you a second case. I'm not sure why they're both triglyceride focused, but anyway, a second case. And this is off my diagnosis list, straight lifted from my letters. A gentleman who's in his early 50s, referred with chest pain, with hyperlipidemia, total cholesterol of 10.4, triglycerides 18.1, history of anxiety and stress, rare consumption of alcohol, and then I had a few other diagnoses which I took out. They've been redacted. And at the time he was on amitriptyline only, but really no medications for lipids. So total 10.4, triglycerides 18.1. So this is what I took out that was redacted. He didn't have screens for thyroid or diabetes when he was sent to me, but we did those and they proved to be normal. He was on amitriptyline, also herbal supplements. There weren't clear dietary factors for his high cholesterol. He wasn't consuming lots of saturated fat, wasn't consuming much alcohol, wasn't binging on lots of sugar. He'd been seen by a naturopath and had a variety of supplements, which I didn't really know what they were. They were quite generic in their terminology. They weren't standard supplements. And he was on amitriptyline. Amitriptyline has been described to put up triglycerides. So I told him to stop that. I organised a screen for diabetes, checked his thyroid, and thought, see you again in a couple of weeks. So this is again straight off my problem list. So the diagnosis number 2, the cholesterol was 10.4, triglycerides were 18.1 in April 2020. A month later, simply by stopping amitriptyline, his herbal supplements, total drop from 10.4 to 7.5, triglycerides from 18.1 to 10, substantial drop. Glucose tolerance test was negative, And at that stage, because his triglycerides were still quite high, I started fenofibrate with fish oil supplement. And fish oil works quite well. Okay, there's a question here. How effective is fish oil and how much do you prescribe? Any contraindications? So fish oil is quite useful in treating triglycerides. Quite high dose, 3 grams per day. Contraindications, some people get GI upset from it. I've heard some people suggesting there might be some prostate issues. I haven't seen the data on that. You might know more as the audience than me. I heard that recently. So I saw him again about 6 months later. So we've had him now, triglycerides down to 10, starting fenofibrate and fish oil. Again, this is my letter. So you have to follow diagnosis number 2 was 10.4, 18.1 in April. In May 2020, it dropped to 7.5 and 10, just with changing herbals and amitriptyline. On a combination of fenofibrate and fish oil, total cholesterol dropped to 4.6 and triglycerides to 2.5. Very substantial drop from 10 to 2.5. Now, I didn't think this was good enough. I did not like his profile. As a gentleman who's had very high triglycerides, he's left with a low HDL. His LDL was not at a vascular target. His triglycerides weren't at the target I'd have for triglycerides. So I added Atozet, apologies for using a generic name here, trade name here, but I added atorvastatin ezetimibe 1010 to his fenofibrate and fish oil. So I've done exactly what I was saying in the last case you want to be careful with, but I've gone with a low dose of statin. And fenofibrate is a good choice because his predominant lipid abnormality was triglycerides. So he's on a combination of 4 lipid-lowering agents, ezetimibe, atorvastatin, fenofibrate, and fish oil. So I saw him recently. So you can follow down diagnoses number 2, 3, 4, and 5, April 20, May 20, November 20, and then a few weeks ago. And on the combination below, now total cholesterol is 3.1. His HDL is 0.6. Yes, it's below where I'd like to see it. His LDL is 1.6, and his triglycerides have dropped to 2. So it's an instructive case of how you can increase therapies with a view to getting predictable outcomes. I told the gentleman top end that he's going to need a number of medications to achieve the cholesterol target I want to get him to. But rather than hitting him with everything at once, it's been a sequential, and at least in terms of the statin, a modest dose of statin to get him to this target. So, are there any questions at this stage about anything? Okay, everyone must be hungry. The dose of fish oil. 3 grams per day I gave them. So 500 milligram capsules, 6 capsules per day. So I thought I'd just bring it back to a more generic discussion about management of lipids in 2021. And I was mentioning before I was going to talk about diet and exercise, and this is where dietary therapy Mark Crawford's coming back with, should he increase alcohol? Mark, I'm not sure, certainly not in terms of triglycerides. You shouldn't increase alcohol. There is some data, well, it's very strong data that alcohol will increase your HDL cholesterol, but it also increases triglycerides. I remember one gentleman years ago, he had the worst triglycerides I ever saw. I think his triglycerides were about 110, 112. And I was even worried about this. And I took a history from it, and it worked out this gentleman worked hard physical work all day and went home at night and drank a slab of beer, 24 heavy cans of beer every night got up the next morning, and went to work. His triglycerides were 112. So I take extreme alcohol as being a cause of very bad lipids. A modest degree of alcohol might be beneficial for HDL cholesterol, but I think in this gentleman, he exercises a lot. I think he's just got a problem where he has metabolism which is directed towards production of more triglycerides with low ApoA production, low HDL levels. I'm going to talk about diet. This is a very good review of diet. American Journal of Medicine 2020, you've got the reference there. This is a review of all the cardiovascular diets which have been proven or postulated to be beneficial. And so I recommend the review to you, but I've just got some summaries from it. Sorry, it's a bit small on the print here. So the traditional recommendation that I'd give my patients is the Mediterranean diet. And the traditional Mediterranean diet is rich in fruit, legumes, nuts, whole grains, fish. That diet has been extended by a study called PREDIMED. Now, PREDIMED is also a very useful diet. It's published in NEJM in June 21, 2018. So if you Google PREDIMED, P-R-E-D-I-M-E-D, it's a very interesting diet. The quotes here are lifted straight from the study. I'm afraid I didn't realize it was going to be so small on the screen. Anyway, they took people with high cardiovascular risk and it's a Spanish study, they're already on a Mediterranean diet, but they supplemented that diet with extra virgin olive oil or extra nuts. You had three groups of people. One got the extra olive oil. They gave them 1 litre per week, a litre of olive oil per week to the matriarch of the family. They said, please use at least 4 tablespoons per day. A lot of olive oil on top of what people were doing normally. The second group got nuts. A mixture of almonds, walnuts, hazelnuts, 30 grams per day. The third group were a bit upset because they didn't get anything. In the end, they got vouchers for shoes. Otherwise, they were upset and were leaving the study because everyone else was getting free olive oil or free nuts. So you have these three groups, and they found quite significant benefit for people having olive oil or nuts. So I'd take back that traditional Mediterranean diet and say, add it with more high fiber, maybe less fruit, maybe more vegetables, limited saturated fat, and use olive oil as your preferred fat source. There's a few other diets coming around. Ketogenic diet, I'm sure we've got patients everywhere on ketogenic diets. Basically what you're doing there is you're tricking your metabolism by putting a high fat diet in place. More than 65% of your calories coming as fat, avoiding carbohydrates, having modest protein. Very good diet for losing weight. Short term, you'll get an increase in HDL and lower triglycerides and a drop in blood pressure, which has been validated up to 10 points after a ketogenic diet for only 1 month. It does drop glucose and hemoglobin A1C, but the long-term studies aren't there, and it goes against my grain of this high saturated fat diet. So if I was having people coming to me saying they want a high fat ketogenic diet, I'd say get the fats from olive oil, avocados, nuts, and oily fish, not from saturated fat, animal fat. The other interesting diet that's become more researched recently, and this is out of that same D'Souza review, is intermittent fasting. Now, some people use an alternate day fast or cut back on calories. Others will just have their calories during a certain time period of a day. They're looking for a 16-hour period with no calories. So do your eating, say, between midday and 8 in the evening, and then pretty much fast until midday the next day. Again, it does drop weight, drops LDL cholesterol, blood pressure, fasting glucose, insulin levels. And it's not a diet where you're putting high saturated fat. This is an interesting dietary concept. And so a lot of my patients are coming back to me saying they're doing this intermittent fasting diet. There's a lot of people pushing this sort of diet. I don't want to give you the impression I'm pushing it. I'm just saying these are the diets which are out there. And I think it's an interesting diet that needs further research because it does appear to have a number of the cardiovascular risk factors move in the right direction. So in 2021, what I'm telling people And I summarize this by calling the diet a fish-eating vegan diet, but people don't seem to like that very much. In terms of Mediterranean diet, I tell them to leave the fruits as less component, have more vegetables, legumes, nuts, whole grains, have plenty of good fat, olive oil. The PREDIMED study is very instructive. Avocados, oily fish. If you are looking for weight loss as part of this outcome, intermittent fasting might be an interesting strategy, and view sugar, saturated animal fats, and particularly trans fats as the enemy. Surely there must be a few comments, if not questions. Okay, I'll take that as no comments. So I'm going to move back onto management of hyperlipidemia. We've gone through diet. Thank you, Mark. Exercise I mentioned briefly before, the Heart Foundation guidelines. There are basically 4 agents which we can use in lowering cholesterol. We're not using much Questran anymore. I have a couple of patients on it only. There will soon be a new class of agent available. Inclisiran will come next year, which is a long-acting PCSK9 reducing medication. But at this stage, 4 medications. So it's been fairly didactic. I was hoping for more engagement, but I'll run through a few things which might reinforce the case studies and give you a few of the things which I think are important in management of hyperlipidemia. So, statin therapy. Okay, Louise is asking impact of high heat during cooking of olive oil. Yeah, I've heard this a lot, and it's been the traditional oil used in Mediterranean cooking. The PREDIMED study is quite instructive in this. They used it as their predominant cooking oil because that's where they're pushing the study. I've heard that some of the antioxidants, etc., are denatured at the higher heats, and that maybe the oil is not as good as a cooking oil at high heat. Hasn't been my experience in using olive oil in cooking, but I've heard that before, Louise. Sorry, I don't think it's the answer, the expert answer you'd like. Jenny's asking about the Saro diet, low carb diet. I think the Saro diet's probably moving a little bit towards what I was saying, that if you're going for a low carb diet, have good fats as part of the mechanism to achieve your low carb. I did mention that sugar is one of the enemies in the dietary advice I give. So I don't have an issue with a low carb diet. It's predominantly a weight loss focused diet, whereas this is more a cardiovascular outcome. So it's hence the Mediterranean diet. Sue's asking butter versus margarine. I'd use olive oil as a spread, Sue. I think margarine's a source of fat that I don't particularly like, but I don't want to give you the impression I'm a dietitian. Okay, I'll move on to statins, much closer to home. Okay, so, oh boy, this didn't print up very well on my screen. We can't make this bigger, can we? No, we can't make this bigger. Okay, I'll put my glasses on. You can all have a look at this. Okay, hepatic synthesis of cholesterol, endogenous pathway, begins with the conversion of glucose via acetyl coenzyme A during the Krebs cycle. HMG coenzyme A is the rate-limiting enzyme in the pathway, forming squalene, steroid intermediaries, and ultimately cholesterol. Statins inhibit HMG coenzyme A reductase. So the first paragraph basically says that the body takes glucose, sugar, and makes cholesterol. The rate-limiting enzyme is hydroxymethylglycerol coenzyme A, HMG coenzyme A, that's inhibited by statins. The second paragraph, there's a medication called bempedoic acid. This is a prodrug that's converted in the liver but not in your muscles, because statins do impact the muscles, whereas bempedoic acid will not do that. And that inhibits production of acetylcoenzyme A and can reduce production of cholesterol by the liver. So that's the second paragraph. There's another medication called bempedoic acid. The third thing is basically saying that your liver will pack up triglycerides, cholesterol, phospholipids on a detergent called apolipoprotein B100. Now, I mentioned this to you before. Fats in your blood are carried by detergents or apolipoproteins. The one which is bad for us is ApoB, B for bad. And it's 100 is the molecular weight, ApoB 100. So if you think that's bad, I'm going to go to the next slide. This is that one I told you before. Don't worry about it yet. We're worrying about it now. So this is the liver in the middle. And basically, oops, sorry about that. Basically, glucose goes via acetylcoenzyme A, Krebs cycle, and produces cholesterol. And that's where statins work, production of cholesterol by your liver. It's also where bempedoic acid works. Cholesterol is packaged up with triglycerides and lipoproteins to a molecule VLDL, not a molecule, a micelle. ApoB100 is the lipoprotein that carries the bad cholesterol out to your body, be it for storage or forming foam cells and plaque in your arteries. So this is where statins work. So take-home messages for statins. The most potent statin is rosuvastatin. Rosuvastatin 40 will reduce LDL cholesterol by 55%, triglycerides by 43%, and HDL goes up by nearly 10%. This is straight out of the Crestor PI off MIMS. So it's the most potent, up to 55% reduction of LDL at top dose. If you double a dose of a statin, there's a rule of 6%. You will reduce LDL by 6%. So people think that, going from rosuvastatin 10 to 20 to 40, you're going to get these massive increments in LDL reduction. You don't. Rosuvastatin 10 to 20 is 6%, 20 to 40 is 6%. So 10 to 40 is 12%. It's a rule of thumb. It's not exact, but it's a nice rule of thumb to use. The other thing I'd like you to remember about statins is that you can use very low dose statins. So some people cannot take statins because of myalgia. Some say they can't take any. My muscles are terrible, doctor. I question them and say, when you took the statin, did it happen immediately, or did it take a period of time before this happened? Did it take a week or two before you started getting muscle pains? A lot of people find that they can take a very low dose of statin, rosuvastatin 10 milligrams once per week, without having substantial myalgia. And there's a reference there for a study. You can look at a number of studies, very low dose statins, reducing LDL by 23%, taking rosuvastatin 10 milligrams once per week. The other thing I'd like you to remember is that statins do have side effects. A lot of patients, I don't know any patient who likes taking a statin. They do all sorts of things to a number of patients. I tell patients what they do for you is they reduce your risk of vascular disease. We all know these side effects: GI upset, muscle aching, low testosterone levels, risk of diabetes. One lady told me she wouldn't take statins because they cause cancer, doctor. And I said to her, I don't think they do. She said, well, it's in the PI. And sure enough, if you go looking at atorvastatin, there are adenocarcinomas, benign carcinomas, benign uterine cancers in rats with high dose of atorvastatin. And that was her reason not to take statins. So I tend to listen to my patients. If they have information, I'll say take it on board and try to research that. But they do have side effects. The other thing to remember about statins is they'll reduce your risk, but they don't eliminate that risk. There's a view that, if only he'd taken the statin, or if he'd only taken the blood pressure lowering, then he wouldn't have had the heart attack. Well, That's not kind of true. They reduce our risk, they don't negate it. Okay, so I've given a lot of information about statins. We're halfway through the time allocated, which is pretty good. It's well over halfway through the talk, I can promise you. Are there any questions?
And if anyone would like to ask Dr. Justin a question verbally, just raise your hand and I'll enable your speaker as well if you prefer, or if not, type that in the Q&A box.
Okay, I do have a question here. Does everyone see the question? Or
yeah.
Everyone sees the question?
Yep.
Oh, great. Okay.
Let me just read it back out for the recording.
All right.
Yep.
Okay. So this question from Sumin, the role of coenzyme Q10, red yeast rice, and supplements. Okay. So I'll start with red yeast rice. So red yeast rice was where they found statins. It contains lovastatin in quite a low dose. So red yeast rice is like taking a very low dose of a statin. They're not particularly well controlled in terms of the potency, but they do drop your LDL cholesterol. If people can take red yeast rice and not have myalgia and side effects, it's because the dose is so low. And that I'd never use red yeast rice with a statin because red yeast rice is a statin. It's a lovastatin in low dose. Coenzyme Q10 is an interesting study with coenzyme Q10 where they took a group of people who had quite bad myalgia, had a washout period from their statin for a month, and then they gave them statin with CoQ10 crossover with the placebo, and there was less myalgia in the group on CoQ10. So certainly I'm not against CoQ10. I don't tend to prescribe it, recommend it, but if people are on it, I don't have any issue with it. There are other supplements which do work. The herbalists do have a number of medication, or nutraceuticals we call them, which do drop cholesterol levels. Red yeast rice I mentioned. There's a supplement called berberine, which activates PCSK9 and can drop your LDL cholesterol, depending on the formulation, 10, 15%. And there's bergamot, which is a citrus derivative which drops your cholesterol level as well. So these things do work, and you can also use plant sterols, phytosterols, to affect absorption. So if you think about it, the nutraceuticals are a little bit like what our therapies are. You've got a statin-like one, or a statin, red yeast rice. You've got one which works on PCSK9, berberine. You've got others which are more like ezetimibe, phytosterols, which are binding cholesterol in your gut. So you can, by putting these things together, get quite a good drop in cholesterol, maybe 25, 30%, but it's quite expensive. When do you initiate statin treatment? Okay. All right, look, it's an interesting question. I'd certainly initiate statin treatment in anyone who's had an event. That's the secondary prevention group. In terms of primary prevention, you want to go to your high risk groups. So your risk factor calculators can give you a view of what the risk is over a period of time. I tend to use statins in people who have quite bad family history. And that could be off PBS in terms of prescription, as I showed you top end. Ezetimibe, atorvastatin 1080s, just over $1 per day. It's quite cheap in terms of the agent. So if people had an elevated lipoprotein little a or significant vascular risk factors, family history, I might come in quite early, in their 30s, saying I'd get you onto treatment. Primary prevention group, clearly those who have the highest risk, so diabetics should be on statin therapy. There's movement towards people who have any vascular disease, be it carotids or peripheral vascular disease, to be aggressively treated with statin therapy. So I think probably secondary is easy. The primary is a high risk group, and there's a group outside of that where I'm aggressive but would be off PBS and prescribing that. Okay, so if there's no more statin questions at the moment, you can certainly come back to any of these questions, please. I'll come on to ezetimibe in 2021. Now, ezetimibe was a drug which had no love for a long period of time, but it sort of made a bit of a comeback, partly because of the PBS. You need to be on ezetimibe to prescribe the PCSK9 inhibitors, for example. But going back to this complicated 40 lines of knowledge I wanted to talk to you about before. So this is, I'll put my glasses on again. So the gastric lipid pool contains free cholesterol ingested, cholesterol esters, triglycerides, phospholipids, fatty acids. You get enzymes through your stomach, lipases, which hydrolyze the lipid esters. They're emulsified by bile acids, secreted by the hepatocytes. Now, the NPC1L1, Niemann-Pick-like protein facilitates the transfer of cholesterol from the bile back to the liver. So cholesterol has got its enteric biliary circuit. Ezetimibe blocks this protein. And then you also have micelles, biliary micelles in the gut, which are absorbed in your intestine. Again, ezetimibe blocks this. So to come to our favorite diagram from New England Journal of Medicine, this is called the exogenous pathways. This is what you put in your mouth. All those fats, they'll come into your gut. The triglycerides go through pancreatic lipases, hydrolysis, and you form micelles, which are absorbed using this receptor, the NPC1L1 receptor, and enter your circulation through the thoracic duct. There's also a circulation of bile acids and cholesterol from your liver to your gut and back to your liver. So ezetimibe will interfere with the reabsorption of cholesterol by your liver and by the microvilli in your small intestine. And so they'll stop absorption. So statins are over here on internal production. This is absorption. Use Q score to check statins. So Sushan has asked me about using Q risk score to check who needs statins. I don't myself use the calculator from the Heart Foundation myself, but if the Q risk score is giving you the information you need, I don't have an issue with it. I don't know the Q risk score myself. So the key ezetimibe trial was in 2015, published. It's called Improve It. Now, we're trying to improve statin therapy by adding ezetimibe. It was a big study. There was 18,000 people in the study. It took 7 years. And after 7 years, there was a 2% absolute risk reduction in an ACS cohort, high-risk patients. 2 years to get a reduction of 2% from 34.7% outcome to 32.7% outcome. These outcomes were heart attacks, cardiovascular death, myocardial infarction, bypass surgery. So as I mentioned to you before, statins don't stop all the risk. They reduce it. By adding ezetimibe to a statin, you reduce it further, only by 2%, but it's still a useful agent. This is in a high-risk group who've already had events. It's a useful agent in the most high-risk patients, but also in those who want to prevent an event. Sometimes we're focused too much on treating people who've gone a long way down the vascular process, whereas we should be focusing on trying to prevent these events. So the data from the Improve It study, ezetimibe added to simvastatin, it was 40 milligrams of simvastatin in the study, reduced LDL cholesterol by about 23%. So just for simplicity, we'll call it 24%, okay? So for those who remember the rule of sixes with statins, every doubling gives you 6%. So if you talk about atorvastatin, you start with 5 milligrams. You have 1 doubling to get to 10 milligrams, 2 doublings to get to 20, 3 doublings to get to 40, and 4 doublings to get to 80. So I'd put to you that 4 doublings is 4 by 6% is 24%. So the potency of atorvastatin 5 milligrams with ezetimibe is similar to the potency of atorvastatin 80 milligrams. And in my practice, a lot of people can't tolerate atorvastatin 80 milligrams. They get myalgia. So I use a lot lower dose statin at times with ezetimibe to reach the targets I want to get to. So what are the take-home messages? The PI of ezetimibe also mentioned triglycerides are reduced by 14%. A lot of people think ezetimibe doesn't reduce triglycerides, but it does, and increases HDL by about 3%. Within the Improve It study, those who had most benefit were those who had the highest risk, particularly those who are post-CABG. And so if you can actually use ezetimibe in that high-risk cohort, thinking, I want to get the LDL target down even lower, add ezetimibe to your statin, and use it also to potentially reduce the dose of statin you need to give. I know people are thinking it's costly, but those first slides I showed were quite instructive. You know, ezetimibe 10, atorvastatin 20, or ezetimibe 10, atorvastatin 80 were just over $1 per day cost. They're pretty affordable in terms of modern medicine. Oops, 20. Okay, I'm going to move briefly on to fenofibrate. And I had a couple of cases today where fenofibrate was quite useful in dropping particularly triglycerides. So fenofibrate will work via PPAR alpha mechanism to activate lipoprotein lipase. It also increases synthesis of apolipoprotein A1. So as I mentioned before, apolipoproteins carry fats in your blood. Apolipoprotein B is bad, apolipoprotein A is good. This carries cholesterol from your vasculature to your liver for metabolism. Fenofibrate will reduce total cholesterol, but mainly via triglycerides, up to 50% reduction in triglycerides in the studies. HDL will increase. The PI says between 10 and 30%. Unfortunately for fenofibrate, it has not been shown to have the major morbidity and mortality benefits in a cardiac sense in the diabetic population or the metabolic population where we like to use fenofibrate. It's certainly very useful for vascular eye disease and peripheral vascular disease. So it's used a lot by endocrinologists. I use it for that group where triglycerides are not at target despite statin plus ezetimibe. So I'm moving away from tablets shortly. Are there any questions at this stage? Okay, making good progress. So I'm going to move on to PCSK9 inhibitors. So this is all about clearance of LDL cholesterol from your blood. So, okay. A couple of questions. What about using ezetimibe on its own if unable to tolerate statins? Certainly, I think it's a very reasonable choice. It's going to drop your LDL cholesterol by 20-ish%. And if you can't tolerate statins and you need your LDL lowered, I would certainly use ezetimibe alone. Can fenofibrate increase LDL? It's not been my experience and it's not described in the literature I looked at. So I'm not aware of LDL increasing with fenofibrate.
We think it's only you. Just everyone, just let us know if you're having any other problems. I've noticed that you're dialing in from an international number. I'm just wondering if that's got anything to do with it. But we'll push on. My apologies, no issues for me. All right, we'll keep pushing on. We will be recording this session, so you will be able to view this on our website at a later date.
I hope you're not having any trouble because my voice is almost gone. All right. So this comes out of the New England Journal article from 2019. This is that small print with 40 lines of all you need to know. So efflux, the movement of cholesterol from the arterial wall, the foam cells, the plaque within the wall, to HDL cholesterol is crucial and specific part of HDL cholesterol function. It's called macrophage reverse cholesterol transport. This is what you want to do. You want to move the fat out of your vessels, back to your liver, and metabolize it. LDL cholesterol molecules are taken by the HDL complex to the liver. They bind with LDL receptors and are metabolized in the liver. Now, the liver has a protein called PCSK9 that binds with LDL receptors and clears them. So it reduces the ability of the LDL receptor to clear more LDL from the blood. This is where PCSK9 inhibitors work. Thank you. So back to our favorite diagram. We're heading towards the right-hand side here. So again, these are foam cells, plaque within your arteries. And HDL will pick up cholesterol from the foam cells and will transport it back to the liver. The LDL will bind with the LDL receptor and be metabolized. PCSK9 will bind with the LDL receptor and will not have available for coming back to the hepatocyte to clear more LDL from the bloodstream. So the only PBS available PCSK9 inhibitor at the moment is called Repatha, evolocumab. The AB part or the MAB part is monoclonal antibody into the name. So what it does, the PCSK9 molecule binds with the LDL receptor, and the LDL receptor is metabolized within the hepatocyte. If you have Repatha, the inhibitor of the PCSK9, it binds together. The LDL receptor can be recycled back to the surface of the hepatocyte and can remove more LDL cholesterol. So you're increasing the ability of the liver to clear LDL cholesterol from the blood. That's the mechanism of action. Okay, there's a very good question coming about young people with statins. I'll come back to that after I go through the PCSK9, if that's okay. So the key study for Repatha for evolocumab was called the Fourier study. The things to remember about this study is it's an add-on to statin, and they'd been on statins for a period of time. They were stabilized. And they added on evolocumab, 140 milligrams every 2 weeks, or 420 milligrams once a month, or placebo. They continued the statin. And the entry LDL average was 2.4. So it's quite a low LDL. They looked at cardiovascular death, hospitalization, MI, stroke, the standard primary and secondary endpoints you can see on the slide there. So what does it do? It drops your LDL cholesterol by 59%. Now, for those who are listening, the most potent statin was rosuvastatin, 40 milligrams, dropped it by 55% in the PI. Ezetimibe by 24% on top of a statin. This is 59% on top of a statin and ezetimibe. So you're getting your cholesterol levels right down. And it seems to be fairly persistent. It is well tolerated. Very minor issues in terms of access site injection that cause some irritation. I'd have probably 20 or so patients on this, and it's very, very effective. So we now have an ability to really lower people's cholesterol. I'm going to go back to, okay, this is the Fourier study. Okay, so reduce cholesterol by LDL cholesterol by 59%. 42% got their LDL below 0.65. That's remarkably low. It reduced all the hard endpoints we're looking at in combination, although it didn't reach mortality benefit if it was looked at alone, but the trends are all in the right direction and the primary and secondary endpoints all met their predicted benefit. So, number needed to treat. It's interesting as well. The second year was more effective than the first year. So it seems the benefit is going to increase with time with these therapies. We've seen that with statins as well. Number needed to treat over 3 years was 50 to prevent death, MI, stroke. So I've asked a few times what your cholesterol goals are. Have people, I know it's sort of an open forum, there's nothing that's right or wrong here. I think the Heart Foundation said less than 1.8. How aggressive are people putting their cholesterol goals? We'll go simple to LDL cholesterol goal. How aggressively are you going for a very high risk patient, e.g. Mr. FH, the case earlier today? Any takers? What's the LDL target? What, less than 1.4? I like that. That's more aggressive than the Heart Foundation. All right. I'm going to go to another complicated slide. I'm sorry, but I'll try to make it simple for you. This is the European guidelines, 2019. So basically, they are trying to push concept of risk. Okay, so if you're a low risk person, LDL cholesterol of 3 should be your target. The small print down here, the very high risk group, okay, less than 1 LDL cholesterol. And this is a group who have atherosclerosis, secondary vascular event within 2 years. So Mark was mentioning less than 1.4. I've used that as a target for a long time with LDL cholesterol, but I've got a group of people who have progressive plaque despite an LDL cholesterol of less than 1.4. And I'd like to remember the target is less than 1.4. 1.5 is not good enough. That's not less than 1.4. So you want to be fairly aggressive in meeting these targets if you can, if people can tolerate them. So within the European guidelines, the high-risk group, less than 1.8, that's the sort of primary prevention group we have with diabetes. A very high-risk group of people who have established cardiovascular disease and have had events. And then within that, even less than 1 being pushed down the LDL cholesterol to lower than 1 to achieve it in those who have more vascular events despite LDL of less than 1.4. So in terms of treatment, you start with diet and exercise, okay? We've been through that a little bit. You add statin as first line. They're saying the highest recommended dose to reach your goal. Highest tolerated dose. Okay, so I'd be using either rosuvastatin or atorvastatin being the most potent. And I'd start with a dose which might be 10 to 20 milligrams, but tell people it is likely we'd have to escalate the dose. I'm giving you a trial dose at the moment. If on the highest dose of a potent statin, they don't get to their target, be your target less than 1.4 or 1.8 for primary prevention or less than 1 for the very high risk group, you add ezetimibe. Okay, so that will give you another 24% reduction in LDL. If you've not reached your LDL target, this is European Cardiac Society guidelines, you consider adding PCSK9 inhibitor. And so it's a stepwise process of statin, maximum dose, ezetimibe, PCSK9 inhibitor. So if we talk about Mr. FH, his initial LDL cholesterol might be about 8. So what will we do for Mr. FH? We put him on well, we didn't actually give him atorvastatin, but if you gave him rosuvastatin, the most potent statin, you get a 55% reduction in LDL. You drop his LDL to about 3.6. You add in ezetimibe, another 24% reduction, you're down to about 2.73. Now, this is the group where you can use Repatha on a PBS script. If you've had stable therapy for 3 months of maximum statin and ezetimibe, and your LDL cholesterol is more than 2.6, and you have vascular events with stenoses in more than 2 territories, you can add in evolocumab on PBS. That will give you, in the trials, 59% reduction, heading the LDL down to 1.12. So we're coming down from 8, almost just over halving it with the statin, another quarter off with the ezetimibe, and you halve it plus again with evolocumab. Okay, I've got a question about European guidelines, I believe, if that's what Shavita's asking. Why didn't they consider fenofibrate? This is an LDL algorithm. So fenofibrate is predominantly a triglyceride treatment, and this is really the guidelines for LDL management in atherosclerosis. Okay, so I'm going to come back to Sumin's question here. I'll just read it out. Young women of childbearing age who have probable FH, at what age and cholesterol level would you consider starting statin? It's contraindicated in pregnancy. If you choose to monitor and not treat, how frequently would you repeat a lipid profile? Okay, so I agree. I mentioned to you before, statins have a whole series of side effects which I don't particularly like. And they're the best we have affordably for groups that we're using them in, but they're not perfect drugs. They should not be used, certainly during pregnancy, absolute contraindication. I'm nervous if people are trying to fall pregnant. I don't like using statins in that group either, although provided they're stopped quickly during pregnancy, this seems to be quite safe. So I tend to try to avoid them if people are looking at having children. You're talking about a probable FH. You're talking about someone here who has, I presume, LDL cholesterol, a bit like Mr. FH's, total cholesterol of 13, LDL of 8 plus. I'd be using statin, but taking it off if they were about to try to fall pregnant. If they did fall pregnant on a statin, you'd stop it immediately and have them very well aware of that. In terms of how often do you repeat the lipid profile, maybe every 6 months or so, but you won't get good news unless you can get onto these very strong therapies. Okay, briefly, I'm going to talk about when to de-escalate therapy. I've never been asked that question before, although people do say, do I need to take these tablets forever, doctor? And I say, no, not forever, because if you can pattern your vascular health until you're aged 80, then probably you don't need them anymore. But I don't tend to keep people on them forever, but I haven't been asked this question in a talk before. So when to de-escalate? Certainly if people are getting side effects. So a washout period without the statin, retrialing a very low dose of statin, considering ezetimibe with a very low dose of statin or ezetimibe alone would be a period to consider de-escalation. If you've exceeded your LDL target, sometimes you get a surprise and LDLs are down at 0.6 and 0.7 and 0.8. Now, if they've got very aggressive vascular disease, I might leave the treatment ongoing, but I have historically and would still de-escalate therapy if the LDL was beyond the target that I was hoping for the patient. There are certainly trials available where people are in terminal illness, 12 months to live sort of situations where they've de-escalated therapy with statins and it's not caused any harm. People don't like taking lots of tablets. There's financial costs in doing so. There's side effects. There's studies available where people have stopped the statin therapy at the terminal phase of cancer illness in particular. So I don't think that's at all unreasonable. In fact, I think it should be recommended. Some people talk about stopping at a certain age. Now, I tell people in advance, look, we might stop it when you turn 80. I tell people that when they're 60. When they turn 80, I don't stop them, because some of the data suggests that stopping the statin does cause a rebound harm. There's more heart attacks and strokes in the first 2 years after stopping a statin than the cohort who continue with them. So if people tolerate it well, then I tend not to stop it. I've had a few times where it seems almost futile to continue someone on a statin. People who are, in high-level care, etc. And I had that discussion with the family, saying, I'm not sure there's much to be gained by continuing. And certainly most families are quite accepting of that. So that'd be the times I think you could consider de-escalating therapy. Certainly there's a group in later life who will get little benefit from these agents and potential risk. And so that needs to be considered. Certainly if you're in a terminal phase of an illness, would be a clear group. So I'm not going to talk about this slide again, other than I've terrified you with it. But those 40 lines in that one slide are all you need to know about lipids, where the agents fit, how they work together. And I'd be delighted if there's a few questions or comments. Thanks, Mark. Oh, there's just comments. Thank you, guys. I hope it wasn't too long-winded. Tough talk for an hour and a half, I can promise you. All right, well, there's no more questions. Look forward to catching up with people face-to-face at the next meeting. And certainly if people have any particular questions, feed them back through SAPME or contact me directly. I'm very happy to chat. And thank you for sitting through an hour and a half of lipid education.
Thank you everyone so much for attending. We'll be popping this recording up onto our website, so please keep an eye out for that in the coming days. Upon the end of the session tonight, we will have an evaluation survey which will pop up on your screen. Please do help us by filling out that short survey. That just helps to ensure that we maintain quality education, and hence we will maintain funding if we continue with education like this. So I would like to thank you to Dr. Justin. It's been an excellent session tonight. So if that's it, we'll close the session now. Thanks again.
Yes.